You are listening to the Horse Radio Network, part of the Equine Network family.
Hello and welcome to this episode of the Disease Du Jour podcast. I'm your host, Carly Sisson, and in this episode I spoke with Dr. José García-López about Nuchal Bursitis. The Disease Du Jour podcast is brought to you by Merck Animal Health. Dr. Garcia-Lopez is a diplomate of the American College of Veterinary Surgeons and a diplomate of the American College of Veterinary Sports Medicine and Rehabilitation. He is an associate professor of large animal surgery at the University of Pennsylvania School of Veterinary Medicine, New Bolton Center. He received his veterinary degree from the University of Pennsylvania in 1996. He did a residency in large animal surgery with an equine sports medicine focus at Tufts Cummings School of Veterinary Medicine from 1997 to 2000. Thank you, Dr. Garcia-Lopez, for joining us today.
Thank you. My pleasure.
Can you start by giving us a brief overview of what Nuchal bursitis is and how commonly you see it in practice?
Yeah, so it's a question that if you would have asked me, 15 years ago, the answer would have been very different with regard, especially with how common it is, since we're able to identify it, now more commonly than before. So Nuchal bursa is a bursa, which is almost like a pillow-like structure that is, so we all have bursas, first of all. And bursas are these synovial structures, almost like a pillow, in which you have them in areas where you have a sharp bony prominence and you have a tendon or a ligament that courses over. So, for example, like in humans also, we have like the trochanteric bursa or the hip bursas, in which they're there to basically help cushion as the tendon goes over areas of the hip or the pelvis, I should say. In the horse, we have the nuchal ligament, which goes from the pole region all the way to the withers, and that transforms later into the supraspinous ligament. In order for the nuchal ligament to go from the pole right behind the ears down the cervical vertebrae, you need, right over the first cervical vertebrae or C1, because it's pointy, and the ligament then will take kind of like from a flat to a downward, angle. You need that type of tissue or structure to cushion that ligament, basically taking that sharp turn, and also the top of the C1 is a little pointy. So it would, if you don't have something like that, it would actually damage the ligament. There's also a second bursa, which is called the caudal nuchal bursa. That is also sometimes seen in horses over the second cervical, but that one is one that is not always the case. So not every single horse will have a caudal nuchal bursa, but they will have a cranial nuchal bursa. So then what happens is, and we don't necessarily know why happens to certain horses and not others, but we seem to see it in the majority of the times in horses that usually are athletic and have some sort of high neck carriage, or they do a lot of collection with the neck. So, for example, a dressage horse, but also a gaited horse like a Tennessee Walker or a Morgan that is also going to be, have a fair amount of neck flexion, especially at the head level, could be prone to develop this bursitis. So this is not an infection. This is just inflammation. Every once in a while, they can become infected, but this is different from what people would call in the old days polevo. And that is basically, polevo is an infection of Brucella abortus. This is nothing to do like that. This is actually, it's the same area, but here, we're talking about an area that is inflamed. And then once you get this level of inflammation, not only you have the growth that some people will notice, sometimes if the horse has a little bit of a mane to the side, you might not be able to localize it as well, but then they'll become very sensitive to palpation of the area. Then with regards to how common it is, on all things, it's actually not necessarily a particularly common condition, but it's one that in the last 15 years or so, we're recognizing a whole lot more commonly than before. Before, when we described the first 4 cases that we presented, I think it was in 2010, which was our first publication, people didn't even know that this bursa really existed. Now people are aware of it. And then again, these were just 4 cases that we were able to gather. We did some anatomical dissections. We described the anatomy also in other publications. But as we start looking more into this region and be more specific about these horses with head pain or sometimes neck carriage issues or pole pain, then we've been able to identify it a whole lot more commonly. So it's still not very common, but it's one that is definitely more common than what people thought 10 years ago.
Yeah, that's really interesting. What are some of the clinical signs that might make you suspect that a horse has this condition? Are there any subtle signs that are easily missed?
Yeah, so it's a really good question because, like a lot of things that affect the neck, or some of the behavior changes that a horse may have, sometimes those signs could be non-specific. So you have a horse that it's either, doesn't like to be, to kind of, go into nice neck collection. A horse that sometimes prefer to stay with the neck extended and a little bit lower, kind of almost at like shoulder level. Those are things that if they're present, I would be also, as part of my physical examination, I will be looking at this whole region also. You will see the more, obvious signs is if you have a horse that also doesn't have, much of a coat, that is being clipped, and you look at, right between the ears, and you move the mane, you will notice that there's an asymmetry. The bursa sits right in the middle of the neck. It's in midline. But when it gets inflamed, and it's kind of bilobe, so it has like a left side and a lateral side, but it's only one. There's basically almost like a figure of 8, with kind of like the narrow part is where the ligament sits. And when it gets inflamed, a lot of times will go from one side to the next. It's almost because you have pressure from it's almost like if you have a pillow and your head is on the pillow, and your head is putting pressure, and the pillow is very stiff. It's going to sometimes go one way or the other. So you may see swelling on the left side or the right side of the pole, and it's one that usually, when you in the more significant, on the moderate cases or severe cases, you touch the area, and the horse will be very apprehensive. So you might notice a horse that when you try to put a halter on, the horse gets very, very wound up. So, those will be those type of subtle, sometimes changes. And then when you're careful, you're looking at the neck, at the pole, you'll notice that there's some asymmetry. But sometimes you'll just see them with just loving to keep a low head carriage and just keep that neck a little bit more extended and really grinding its teeth, not really wanting to stay on the bit when you have them nicely collected. And sometimes you'll see some attitude changes, that they just get pinned their ears, they get angry, and people think, oh, could it be the size and stuff like that? So anything that is kind of changing the behavior of a horse, especially when you have them in a certain frame, it's as part of my evaluation, I will be looking at that area.
Today's Disease Du Jour podcast is brought to you by Merck Animal Health's Protozil 1.56% diclazerol anti-protozoal pellets. Get the scoop on Protozil easy to administer top dress alfalfa pellets. A safe and effective treatment that starts working fast without a loading dose. Learn more at merckanimalhealthusa.com. Do not use Protozil in horses with known hypersensitivity to diclazerol. Safety has not been studied in breeding, pregnant, or lactating horses. For complete safety information, please read label. So how do you go about diagnosing the condition, and how do you differentiate it from other conditions, maybe when you're looking at images?
Yeah, so that's a great question. So it's one of these conditions that we a lot of times do a two-prong approach when it comes to diagnostics. The diagnostic that we would do more commonly, it will be ultrasound. So we do an ultrasound of the area in which you can actually see the bursa. The bursa in a normal horse should not really be visible. It's when we did our anatomical studies, the volume of that bursa is literally like 1 ml or less. So it's actually a very thin structure. Then when it gets affected, then you'll actually start filling up with tissue and fluid. And so, an ultrasound, if you can actually also almost see the bursa when you're doing a study under the, rectus capitis muscle, which are the muscles on the side of the neck there, then you're already seeing something that is not normal. So ultrasound is one of those first lines of defense from a diagnostic imaging standpoint. Also, the radiographs come handy because some of these horses that have more of a chronic change, you'll see mineralization at that area of C1, just dorsal to C1, which is mineralization of the ligament or the capsule itself that starts, getting affected. And that's a change that will tell you that something's been going on for a little bit of time. In some cases, if you don't have the ultrasound expertise to look at the area because it's a little bit of a funky area in ultrasound, you can also do a CT scan, which can also show you very nicely, especially if you have a CT scan with a bone mode and a soft tissue mode, you'll be able to see that you have an enlarged area that is abnormal, and then you can then hone in your ultrasound. But to me, the bread and butter when it comes to diagnosing these cases are ultrasound and radiographs.
So I know we already talked about breed or build being a risk factor for the condition, but are there other causes or other risk factors associated with it? Is it the result of trauma, or are there any other contributing factors that you've noticed?
Yeah, so good question. So a little bit of a loaded question there in the sense of, again, we see some of these horses that are, in disciplines that have quite a bit of, neck flexion, etc. So that potentially may be a predisposing factor. We've had some horses in which they can develop quite a bit of inflammation when they get randomly injected in the pole area without necessarily any diagnosis. So you have to be very careful just randomly injecting the area. We've also seen, and this has been, and again, the problem here is that, still working on what's the significance here. But we've seen a subset of these horses that, so when we're doing surgery, we're obtaining samples of the lining or the contents within the bursa. And we actually were able to get a subset of horses to basically be positive or grow Borrelia burgdorferi, so the Lyme disease. So whether it's horses that have been exposed to Lyme and then it happens to seed in the area and causes inflammation, or is it is it a horse that is in an area with high level of exposure to Lyme and it just gets seeded there and may not necessarily be part of the whole why it became clinical. So that's part still to me a little bit unknown, but one of the things that we do when we do surgery on these horses is submit samples, because we get, again, it's out of 10 horses, maybe 2 grow, so it's not very common, but it's still one that if it grows, then we may actually do some different antibiotics to work with them.
Yeah, interesting, the connection with Borrelia burgdorferi there. I know that's something that you're still exploring, but I think that's definitely interesting how tick-borne diseases can impact your diagnosis. Could you walk us through your typical treatment approach to the condition, from conservative to management to more invasive intervention?
Yes. So that's a really good question, because it's actually where sometimes we get into trouble, to be honest. So one of the things that we've done when we did our retrospective, in which it was basically a large group of horses in 2 different locations. One, it was in the Northeast, and then the other location was actually in the Netherlands, which a colleague of ours in the Netherlands. So one of the things, when we looked at all these horses and how they did with medical management and surgical management, they seem to have certain characteristics that when you diagnose them, if you diagnose them early in the disease, in which when you do your ultrasound, the fluid within the bursa, it's kind of clear, meaning that it's effusive with not a whole lot of cellularity, those horses may benefit from actually having an injection of an anti-inflammatory such as a corticosteroid in there. And then to bring down the inflammation, not dissimilar to what you do with another synovial structure. However, when we saw that the horses that are a little bit more chronic, in which now the swelling that you see in the pole, the enlargement of the bursa is more because of the capsule is thickened, or the synovium or the tissue within it is quite proliferative. So rather than just having nice clear fluid inside, it's a fluid that is very echogenic or very dense. Those horses not only did not respond to that same medical management, but actually were the ones who had the most complications after if you went to the surgery. So, as a rule of thumb, the way that I go about it at this stage is that if you have a horse that on ultrasound, it looks, the walls of the bursa are thin, the fluid doesn't look very cellular, that medical management with an anti-inflammatory injection, ultrasound guided, could be, very beneficial and help. But if when you do the ultrasound, you have mineralization, or you have thickened capsule, or proliferative synovium within it, or just very cellular fluid, I would actually recommend surgical intervention versus medical management, because I do worry that not only it's not going to help, but if then you have to go into surgical management later, then those are the ones that have, that were the highest rate of complications postoperatively.
And what does the surgery involve exactly?
Yeah, so the surgery, it's basically a minimally invasive procedure called a bursoscopy. So it's similar to when you get your knee scoped, in which you use an arthroscope, in which here's, it's called an endoscope. It's a rigid endoscope, in which you, rather than putting in a joint, you're putting in a bursa. So you're, through a stab incision, you're putting a scope inside of the bursa so you can actually visualize all this tissue. And then you use another instrument, another incision, which is usually each of them are kind of like half an inch, quarter of an inch big. So they're small, in which you can put instruments in there to get rid of all this tissue. So you can do what is called a debridement of the tissue so you can get rid of it. That's also where we get the samples and submit them. And that way you basically are getting rid of all the inflammatory tissue within the bursa just to allow the bursa to calm down.
So after treatment, what does the rehabilitation process typically look like? And I'm sure this is very different depending on the extent of the treatment, but can you walk us through that process?
Yes. So it's also a very good question because, like you said, it will depend. Let's say that we have a horse that the bursa looks effused with clear fluid and you go with medical management there. Those horses, I usually will rest them for like a week in which they can either be hand walked or a small paddock. Then I get them back under saddle working, but the first week or two, I actually get them working long and low, just so they're not putting a whole lot of pressure on that pole region. And then after that, start to increase the tension, et cetera, and move on. The horses that undergo surgical management, those ones will need to have usually 2 weeks of stall rest with hand walking, obviously. And we protect the area with these adhesive bandages. Doesn't get it. It's the same way that you put a bandage in the leg, we put a bandage over the area. But this time we just put a sticky so it stays over that area, right, and wrap around the neck entirely. And then after the 2 weeks, then I get them 4 weeks of stall rest with hand walking. At 6 weeks post-operatively, I usually like to do an ultrasound to see how the tissue is responding for the debridement, make sure everything's settling nicely. And if that's the case, then I put them in a small paddock for another month. Then after that, I keep them in the small paddock, but then start doing some walking under saddle exercise, long and low, for another couple of weeks. So that will take you to the next 6 weeks. So it'll be 12 weeks after surgery, 3 months. Then I do another ultrasound, and if things look good, then I get them back into more work. Same thing. First, a couple of weeks long and low, and then they start getting more collection. So it usually takes around 12 to 14 weeks, if everything is going right, for them to go back to pretty regular work.
What is the typical prognosis in your experience, and do you have any issues with recurrence?
Yeah, so that's a great question. So the ones that are acute that go with the medical management, those ones seem to respond quite well, and very rarely they'll seem to have a regrowth of the bursa. The ones that you go surgically, we are basically between 75 and 82% of those horses, everything gets resolved and it's not an issue anymore. The other, depending, 25% or so, either have a recurrence of the bursitis. Sometimes they'll also develop fistulous tracts from where you did the surgery and start draining, which also becomes an issue. And those seems to be more on those chronic ones that were treated medically with injections and messed around with when you go. So that's where, like, the horses that had the severe changes or significant changes and then were treated with steroid injections and then went to surgery later, those were the ones that either needed a second or a third surgery, or the ones that developed tracts in which then there was drainage that either you have to be revising it until they finally close, or you had a couple that actually were euthanized because of the consistent drainage. So it's one that's where identifying it early makes a big difference. But if you by any chance missed it, because sometimes you will not notice it until all of a sudden you have the clinical picture, and it's more, when you do the workup, it's been more of a chronic thing that went underneath detection. That's where, based on that appearance, knowing whether you go the surgical route or the medical route, to me, in my opinion, makes a huge difference on how they do later.
Does the horse's age have any effect on the prognosis? Is it better for them to be earlier or later in their career, or older or younger?
We didn't see a relation between the age. Obviously, if you have a 22-year-old horse with this, then you have to be a little careful because they, as you get older, we don't heal as well as when we were younger. But in our studies, we did not see a correlation between age and outcome. So in theory, if you're an athlete, whether you're a 7-year-old or a 13-year-old, it should not make a big difference.
Okay, that's interesting. Is there anything else you'd like to add on the topic before we wrap up?
I think it's an interesting condition that we're still learning, especially with some of these Borrelia effects. And again, how all of this plays a role. I think it's one that, even though it's not common, if you're a veterinarian and or a rider, and you're noticing you have a horse that has a progressive change in attitude or this low head carriage or something that is making them not perform the way that they were either performing previously or not getting to the point that they should, I think is an area that we should consider looking at just to at least to rule it in or rule it out. Because again, 9 out of 10 is not going to, or 8 out of 10 is not going to be a problem, but it sometimes can be the reason for all these complaints because of how non-specific they can be, especially early on.
Great. Well, thank you so much, Dr. Garcia-Lopez, for joining us. And thank you to our audience for listening. And a very special thank you to our sponsor, Merck Animal Health, for allowing us to have these conversations. If you have any questions, suggestions, or feedback for the podcast, please send me an email at csessin@equinenetwork.com.